Hello and good morning, everyone out there in webinar land. My name is Jeff Buckley. I'm the Director of Insights. My great pleasure to welcome you here today and our panelists as they pop up. This is our last Insight Apsard webinar for the year. And firstly, I'd like to acknowledge the traditional owners of the lands in which we're gathered here today and pay respects to elders past and present. I'm sitting here on unceded Jagera and Turrbal lands in Meanjin in Brisbane. And I'd like to extend that same welcome and acknowledgement to all of the lands and waterways wherever you are, dear webinar guests out there online. I'd also like to recognise the lived and living experience of people with substance use and substance dependence, mental health, self-harm and suicide, and their family and carers as the reason why we're ultimately here and for all of the work that we do in this space. So I'm very excited to rekindle the fireside chat format that we trialled last year for our last webinar, the You Can Ask That. With all of the questions and topics that's submitted by you, dear listeners and viewers, over the past few months, and put them to our panel of esteemed experts and guests who we have here today, and who will actually kindly ask to introduce yourselves and to just like to say who you are, your role, and kind of essentially what you do to our guests who maybe don't know who you are. So I'll just quickly go around the screen as I see you and ask you, Niki, if you could just introduce yourself first.
Yeah, thanks, Jeff. Hi, everyone. Thanks for having me. I'm Niki. I work at QuIHN. QuIHN is the Queensland Injectors Health Network. I've been there now for over 10 years in a variety of roles. I'm currently working on a peer leadership project, which is about it's essentially about improving our QuIHN workforce and how we involve and include people who use drugs and peer workers within our organisation. I'm also a director of QuIHN, Queensland's drug user organisation. And obviously, have a lived and living experience of substance use.
Excellent. Thank you so much, Niki, for joining us. I'll throw over to you now, Rebecca.
Thanks, Jeff. Hi, everyone. Rebecca Lang, CEO of the Queensland Network of Alcohol and Other Drug Agencies, the peak for the non-government sector here in Queensland. In my spare time, I'm also a member of the Australian National Advisory Council on Alcohol and Drugs, director of the National Peak, the Australian Alcohol and Other Drugs Council, and just because I don't like Saturdays very much, I'm also a director of Unharm.
Excellent. Thank you so much, Beck. Great to have you with us. Cameron.
Hi everybody, I'm Cameron. I'm social worker, team leader of Dovetail, Youth, Drug and Alcohol Statewide Clinical Support Service.
Thank you very much, Cameron. I'll throw over to you now, Jeremy.
Thanks, Jeff. So I'm working here at Hayllar. I've been here nearly 20 years now in the alcohol and drug service, so thank you.
Excellent. Jeremy's the clinical director. Yes, thank you. And introducing Kim Minniecon. Hi, Kim.
Hi, everyone. My role here at Insight is the Aboriginal and Torres Strait Islander AOD Workforce Development Coordinator. I'm taking on Chloe's role. As you know, Chloe has gone on maternity leave. I'm excited in this little space. My connections are to the Cubby Cubby, Garang people, and the Morgal and Arab people of the Torres Strait. And happy to be joining today. Thank you.
Excellent, thanks. And yes, it's only Kim's third week in the job because our good friend and colleague Eddie Fewings, unfortunately, who was on this panel, had to pull out at the last minute for another kind of obligation, and Kim has kindly stepped in. So thank you, Kim, and welcome to the panel, and thank you all for joining us. So as you know, well, you may not know, but we have a huge number of questions and topics which have been sent through. So we've done our best to kind of amalgamate and theme them as much as possible so we can get through many of them. And we do have a chat, which you can drop comments and questions, but I can't promise that we'll get to them. But please do drop that in and we'll see what we can do. I'll get started and we do have a few questions, so I will encourage everyone to kind of chew through them as quickly as possible. But as my prerogative as the host of this webinar, I'm going to throw my own question in very first because it's very topical right now, and that is that there's been a recent spate of poppy seed related poisonings across Australia, including here in Queensland, which has just led to a national recall of Hoyts and other poppy seed brands from supermarket shelves. This is just happening as we speak. So I might throw over to you, Cameron, because I know we've had some discussions about this already. Tell me, what's the situation? What is the ingredient or compound that's causing these poisonings? And how should we be responding?
Excellent question, Jeff. Thanks for asking. So many of you might be aware of this issue that's recently broken, probably in the last week. There's been Queensland Health put out an alert last week, and I think New South Wales, Victoria, Western Australia have since followed regarding poisoning occurring from the consumption of poppy seed tea. So some of you are probably aware poppy seeds poppy seeds themselves don't contain opioids, but there are sometimes opioid latex left over on the outside of the poppy seed shells. So there's always been a sort of, this has been kind of known for a long time, and we have seen people over the years using large quantities of poppy seeds, which they make into a tea in order to wash that, often usually morphine off the outside of the seed to make a tea to get an opioid-like effect. So that's always been fairly common, and we have had overdoses from that. People can have opioid overdose from doing that sort of thing, but in general, it hasn't caused too many problems until now. The issue that's just occurred is a little bit unusual in that the poisonings are not associated with morphine. The poisonings are instead associated with a chemical called thebaine. So there are different poppy strains that have been bred, I believe, through genetic mutation to be very high in thebaine content and have virtually no morphine content at all. And those particular strains of poppies are grown to produce the high thebaine content, which is used to make oxycodone. So thebaine is one of the oxycodone precursors. So thebaine, though, on its own does not have any opioid-like effect and is actually really toxic and a poison. So you can't tell from looking at a particular poppy, either a pod or a seed, whether it's come from the pure thebaine strain or the high morphine strain. Pure thebaine strain poppy seeds are never meant to enter the food stream at all because people can get poisoning of quite low doses. And even though we've been talking about poppy tea, there are definitely different cultural groups cook with poppy seeds, including large quantities of poppy seeds. We often think of the orange and poppy seed muffin, and that's one recipe, but there's a lot more that do use really large quantities of poppy seeds. So for that reason, thebaine entering the food stream is a mistake somehow in the system that has occurred. So those alerts have gone out. There's just been now today or yesterday a product recall has been announced for a number of different brands of common household poppy seeds. To check that out, I'm just noticing actually there are new brands being added while we are literally speaking. So to check on the recalled product, go to foodstandards.gov.au, which has got a number of those brands. One of the things we just need to keep in mind, though, is that when this alert went out, some states didn't specify what the actual chemical was. They just said that people are getting poisoned from poppy seeds. What that's probably led to is some people believing there are high morphine content seeds out there, and that means people want to go out and try it. And so we are possibly at the moment seeing a bit of a backfire in some of those alerts that have actually encouraged people to go out and try something they might not have otherwise done. So I know obviously the Queensland alert did mention thebaine as the issue and thebaine poisoning is the problem. And I think it's a lesson for us that we really, when we put out alerts to people, we do need to give people lots of information. We shouldn't be scared of holding back on, technical information. We need to give the information to the people who need it. And I think telling everyone thebaine poisoning is the problem is a useful place for us to start. So yeah, I think Ben's just dropped that link in the chat there for food standards. So have a look and probably keep checking back over the next day or so as that number increases.
Thank you, Cameron, for the comprehensive response. Does anyone else like to make any comment, particularly around some of the implications for service providers and policymakers when issues like this, which no one can really see coming, but they pop up really quickly? So does anyone have any thoughts around how do we get ready, or how do we respond to these situations?
Just the really obvious comment that this is why prompt response networks are so important. That information is power, and the information needs to be in the hands of the people who are most likely to benefit from using it. So it's great to see that NCRED is progressing the National Prompt Response Network. I noticed High Ground, also great local women's harm reduction based service, is putting out some really great social media, really informative stuff that if you're not following them on Instagram or Facebook, get onto it.
Oh.
Just to say that thebaine is also the precursor for buprenorphine. So poppies in Tasmania are harvested. The thebaine is extracted and sent to Scandinavia, where long-acting buprenorphine is produced, and then it comes back to Queensland to be administered to patients. So it's possible perhaps that it's these particular poppies, thebaine rich, which have found their way through seeds into the market. Although the seeds develop in the dried poppy head, and it's the latex, as Cameron pointed out, which is used for the main extraction. So
thank you. And it also kind of shows that we need to be ready for these. We always need to predict what are the things that could happen in terms of all of the various substances around, and have these alerts kind of ready and checked so that when they do happen, we can act promptly, as a prompt response network would kind of require. So thank you. Okay, thanks for letting me throw that one. Let me go to our other questions that have been submitted by you, dear audiences. And the first one I'm going to talk about is around personal enhancement drugs. So the question is, why are enhancement drugs like Viagra or cognitive enhancers such as modafinil either overly controlled or stigmatized when we're allowed to enhance ourselves in other ways that are probably just or even more potentially risky, such as cosmetic surgery? Who wants to tackle that one? Cameron, I'll throw to you again firstly on this one, and then I'll throw to you, Beck.
Yeah, interesting question. I think some of it is a cultural problem that we've got. We seem to have a cultural framing of drugs that drugs are okay if they're designed to return us to some base level of functioning. Anything that enhances us and gets us above baseline functioning is probably tricky or not right. And whether that's either you having a good time or enhancing yourself in some other way. I think historically we've seen pharmaceutical interventions as designed to fix you when you are broken, but not to enhance you and make you better. And I think that's where things get difficult for us as a culture. And you see, actually, even though we talk about things like cosmetic surgery, that is still quite stigmatized. And I'm sure there's plenty of people who get Botox and don't tell their friends about it, because that is also looked down upon. So any form of enhancement pharmaceutically has got stigma attached to it, whether it's a psychoactive drug or a medical procedure. One that's a little different and is worth pointing out is Viagra. I'd say that Viagra, being particularly targeted at the older blokes who invented it, who also run the world, have then made that a prescription drug and not framed that in terms of enhancement at all. But erectile dysfunction is now a disease, and we're treating it with medication, which helps to reframe it away from what it actually is, which is a recreational drug. Controversial take.
Thanks, Cam. Beck, would you like to add anything to this?
Well, I don't think that's a controversial take, Cameron. I think it's a very evidence-informed take. I mean, I think this person has really highlighted how when you actually dig into it, there's no particular logic or science behind what we decide is okay and what we don't. And therefore it is, as Cam points out, really cultural. And so I guess one of the things I'd like to highlight here is that when we talk about things like institutional racism or institutionalized sexism and misogyny, this is how it reflects. It reflects in as Cam says, the guys who run the world getting access to all the Viagra that they need or want, because they really don't need any Viagra, let's be honest, they want it. But where people seek to enhance their experience other than with alcohol, then suddenly there's a problem. So how you overcome that cultural issue, I suppose, well, what I do is continually remind people that these things were not like logically decided, that actually this is a system that's just evolved over time. And if we did take a moment to like go back and have another look at everything, we would have a very different system than the one we have today.
Excellent, thank you, Beck. Does anyone else on the panel want to chime in or add a comment? Happy to keep moving because we do have a lot of questions. Thank you, Beck and Cam, for that one. Okay, so we had a number of questions around the topic of lived experience, and we know that it's a priority that's been echoed throughout our recent plans that have been released here in Queensland. Niki, I'm going to throw this to you first, and then maybe to you, Kim, second. How do we define lived and living experience in the AOD sector today? And particularly like the difference between personal experience of using substances versus problematic substance use or accessing AOD treatment specifically, and then the role of family and carers in this as well. So, you know, how do we effectively incorporate this broad range of living and lived experience in the workforce without it inadvertently, I guess, diminishing the whole or any one type of experience? Niki, what say you on this one?
Oh, I think we've got a long way to go before we fully incorporate you know, the lived and living experience of people who use drugs and the diverse voices of people who use drugs in different settings. I think that seems to be a lot of discussion or debate around the terminology at the moment and how we refer to people who use drugs within or across the workforce. And a lot of terms are used interchangeably. You know, when I joined a webinar, I introduced myself as someone with a lived and living experience, but sometimes I'm a peer worker. So I think these terms are always used interchangeably. QuIHN has recently, well, we haven't released it yet, but we will shortly, a position statement on the terminology and what we would prefer people use. And I think the important thing is for people with a lived and living experience. I think that the better term to use is a peer, because I think regardless of the experience that you have as someone who uses or has used substances, it's the connection to community that's really important. And the term peer sort of implies that, that you are recognised by the community that you work with or that you support, and so the community recognises you as one of their members, and vice versa. You are identified as a member of that community. So I think that peer and the connection with the community is really important when we look at employing people who have an experience of substance use. So regardless of whether it's kind of, current or historic, the important thing is that connection to community. And what were your other questions? There was a lot of questions in the one.
Yeah, there was, particularly around that diversity of types of experience.
Yeah.
Not only that, but there's a myriad of substance use histories out there as well. So how do we kind of hold it all together?
Yeah. I think that's another interesting discussion area, is how we kind of define who a peer is in different environments. And I think we should aim to get at, depending on if it's frontline work and the peer worker is going to be working with people in a festival environment, that person in that role might look different to someone who's working in a needle and syringe program. So it's that identification with the community again. So those, it might not be the same type of experience depending on the setting. So, one, just because someone has an experience of substance use doesn't mean they're going to, identify with all different communities, I suppose. It's a really diverse group of people who use drugs. So we need to think a bit more about, about the different, I think at the moment, there's probably not enough lived experience or peer roles to, there just isn't enough peer roles in different spaces currently. But I think that's one of the exciting things that, when you talk about trends at the end of this session today, I hope to see that as one of the trends moving forward, that we really work on building our peer workforce across the Queensland AOD space. I think what's important for a lot of services who are employing peer workers is it's that shared experience of accessing services. When you talk about problematic substance use, it's not someone who's just used a bit of pot or, has some MDMA on the weekend, but someone who has that experience of service access and the challenges with that, and can really kind of identify with help seeking and the struggles and challenges and stigma that's involved in that. I think that's a key part of it too.
I could unlive some of my experiences. But unfortunately, that option's not available to me. I hate the term lived and living experience. I think the idea is good. And I think, Niki, you really beautifully illustrated and Kim, you backed her in on the idea that we need to be really specific about what it is we're trying to achieve. And then that's what tells us who our lived or living experience group is. I know the work that we did a couple of years back with QuIHN and QuIHN really beautifully just noted that, you know, drug users, people who use drugs in Queensland are not homogenous, and that where not everyone identifies as a peer. So that's a really important part, right? If you're in the treatment system or you're in the harm reduction system, the relevance of your experience to the people you're trying to support is the most important part of that. I think the bit is we've tried to translate that to a systems level into the policy world. And what we've done in the process of doing that is kind of hold ourselves in the problematic space, which is how you end up with systems that think that we're not diverting people away from the justice system, we're diverting them into a health intervention. So you get these really kind of, you know, that the intention is good, but the delivery actually perpetuates and underlines and probably progresses stigma more than it moves us back to an empathetic space where we look at the whole person and ask, what's going on with you? And is your substance use a big part of what's going on for you? Or is it a big part of what's helping you to manage the rest of what's going on in your life? Because I think the responses to those two situations need to be really different. And obviously things like drug checking, you know, you do want to hear from the people who use MDMA and go to festivals and may not have any other experiences of substance use, because that's the group you're trying to target in that setting. And I don't know that, I think the risk we have as a sector is that we just follow along the mental health peer workforce kind of model. And I'm not sure that's fit for purpose for the mental health system, let alone for our part of the system as well. But I agree with Niki too. There's some really exciting developments, I think, that are going to happen in this space over the next few years. So watch it.
Yes, and we'll learn throughout the process, I reckon. And I think that's part of it is, you know, we don't know where it's going to go, but if we don't go down the path, we don't know where, we won't end up anywhere. So yes, very exciting time. I'm going to move on to the next question, which is around psychedelic assisted therapy. So there's a lot of interest and enthusiasm in psychedelic assisted therapy at the moment, particularly MDMA, psilocybin and ketamine. We're all aware of the potential breakthrough benefits. What are the risks or pitfalls for a sector or society that we need to be aware of as we go down this path even further? And I'll throw this one to you, Cameron.
Sure. Yes, there's a whole bunch of risks moving forward with it. I think what we're seeing right now with psychedelics is the hype cycle, which is sort of well known with other innovations where there's always something new comes along. There's a lot of excitement, and in some cases a bit of overexcitement, which then has a bit of a correction after that. Obviously, the psychedelic drugs have got huge potential as adjuncts to therapy, and there's some great research showing their potential benefits. And I know in a lot of ways, psychedelics really are the dolphins that were caught up in the tuna net of prohibition in the 60s and have all this amazing potential. Having said that, I think what the big risks are right now, I think there's a real big discussion, particularly in probably more so Northern Hemisphere, around the commercialization of those drugs. There's a lot of big pharma companies moving really quickly to patent and tie up some of those drugs, including naturally occurring drugs that have been traditionally used by Indigenous cultures for many thousands of years. And those Indigenous cultures are essentially having their knowledge stolen from them and commercialized and tied up in patents. And that's not unusual. We've seen other types of that sort of exploitation of Indigenous cultures in the past. So I think that's a huge risk. I think we're seeing a bit like medical cannabis, a lot of commercialization risks in tying this up. And ultimately, if something like MDMA therapy for post-traumatic stress disorder is to have its full potential realised, and it does look like it's got huge potential, then it needs to be accessible to all of the people who need it. And that means it needs to be cheap or free. It needs to be delivered through public clinics. It can't be tied up in really, really expensive therapies that become inaccessible to the people who are most likely to benefit. So I think we've got all of those problems. Yeah, on the flip side of that, at the other end of the spectrum, while the regulations are taking a really long time and we've got a lot of desperate people out there, we have seen emergence of underground therapists, some of which probably quite legit and others not. And we're definitely seeing things like sexual exploitation of people in underground therapeutic contexts. We've seen, some of that spiritual bypassing type behaviour that you see in New Age spiritual movements as well, and some real exploitation of vulnerable people from, in some cases, well-meaning therapists. In other cases, I would argue probably not very well-meaning therapists. And so we've got a lot of vulnerable people who are really desperate for help. And that, while it takes us a long time to get the research done and the regulations set and that system to work, then we are having people who unfortunately exploited in the underground pathway, and very hard for the end user to know who is a legit underground therapist and who is not. And so that underground world is unfortunately really risky for people at the moment. So yeah, that's my hot take.
Thank you. And there was that infamous Four Corners episode from a few months back, if anyone wanted to hear about some of those less than reputable kind of operators in action. There was a question that's kind of related. I'm going to throw to you, Jeremy. In private hospital psychiatric units, there's reported escalation in the use of esketamine with people with substance use disorder rather than just treatment-resistant depression. Is this something you can comment on? Like, what is esketamine and what does research say about its use in relation to substance use disorder?
Yeah, thanks, Jeff. So esketamine is the S enantiomer, which is one of the optical versions of ketamine, which we're all familiar with, special K. And it has interesting properties that seem to produce rapid response in patients with resistant depression. So it's taken off, as you mentioned, in private circumstances. The cost is very high. At the moment, I read between $300 and $1,500 per week, depending on the dose. And the dramatic onset of relief of depression is its chief characteristic. The difficulty is how long do you keep going with the treatment and whether there's a kind of endpoint. So in some settings, it seems to be used to gain early relief of depression symptoms, while SSRIs or other conventional antidepressants start to take effect. It doesn't work through serotonin, it works through NMDA antagonism, so a separate pathway, it seems, and not fully understood as I read. However, the cost is really prohibitive for most individuals with depression. So I think there's been quite a lot of publicity around it. Some practitioners are using simple ketamine in doses much less than those which might be associated with party use or the stimulant and dissociative effects that it can have as a substance of misuse. We're all familiar, I think, with the chronic interstitial cystitis, the bladder problems that can develop in those who use ketamine long term. Those effects I don't think have yet been described in people receiving the medication for depression, and it may be the doses aren't high enough, but that's certainly something to be concerned about, as well as altered liver function tests. So I think it's an interesting development. Maybe there'll be some more research to try and characterize better the effects, and maybe some other variants will emerge with less potential for side effects and a greater understanding of their mechanism of action.
And is it effective in treating substance use disorder specifically, or is that more so as a byproduct of the antidepressant characteristics?
Yeah, I'm not aware of it being used to treat substance use disorders. After all, it can cause its own substance-related issues, can't it?
Yeah. Before we move on from the psychedelic assisted therapy topic, does anyone want to make any other comments or additions?
Only to note that this is another one of those really great examples of when, something, if it's used in a particular way, it comes with a bunch of stigma. And like, we don't see a lot of people turning up for treatment for their ketamine use disorder. You do see the physical health problems sometimes for people. And yet, when it makes the crossover into the medication barrier, then suddenly it becomes super expensive. I know we've had similar problems with medicinal cannabis. And the thing we don't seem to think about in these journeys is how we make the product available. We tend to leave that to a commercialized market, which comes with a whole range of potentially not very ethical kind of processes, and it's definitely not being targeted at the people who need it the most, whereas our treatment system, we're constantly having to justify whether we're targeting the people who need it the most, as opposed to being available to the people who select it or who who present with issues that would suggest that they would benefit from accessing some of these substances. I think it also really, and the cannabis one really is an interesting one, because I think, Cameron, you've raised this before, isn't it reasonable to expect that if there are people who would benefit from medicinal cannabis, that some of them would be accessing the unregulated market cannabis? And what is our role as a system to help those people to transition from the unregulated market into a regulated market to reduce their harms around exposure to the criminal justice system? And I don't have an answer for that. And we definitely, that's not part of any of our future plans. I noticed our two new services and the whole of government reform plan that have come out, they're not even really thinking about this space as being that there are, you know, other substances. We're doing kind of in an AOD sector space, we're not doing really anything to prepare for a future where psychedelic assisted therapy is widely available, or thinking about how that should change our practice in terms of our own service delivery. And I think those are the conversations that we really need to start having, because when you leave it up to the TGA, they have a very kind of outdated model of thinking about how things move through our system. I think it's very obviously medicalized, because that's where we've started with these systems.
So thank you, Beck. I will move on to the next question to keep it moving. We're going to talk about supporting families now, and the question has come through about how can we address the gaps in services where families are faced with this kind of decision about whether to accommodate or not accommodate their family member who has a substance use dependence or problem, who's either exiting hospital or rehab or prison, when there's no alternative accommodation options, particularly at the moment when we know that the private rental market is so tight. And families are kind of told, you need to house them or they'll be homeless, which sometimes means having to kind of deal with the chaos and sometimes be even exposed to risk or even kind of abuse in the household because of that kind of nexus of not having any other options. There's no easy solution to this, but does anyone want to make a comment? And I'll probably throw it to Beck and Kim and Niki on this one.
I'd say it's not a gap in services, it's a gap in thinking, you know. No one, like the system doesn't think when they jail someone about how they might be jeopardising their housing on the other side of that equation. My members, residential members, would say one of the biggest issues that people graduating from their programs have is finding suitable housing. We've certainly started to look at, I mean, some of this is a function of stigma, let's be honest. I think that one of the fastest ways to fix this would be to make it that jails cannot release someone to no accommodation. Like, that would be a really great place to start. We've been talking with QShelter, the social housing peak, for the last few months about what we can do to support the social housing sector to think about substance use in their context. Interestingly, it started out kind of being talked about as slightly sober houses, and then it was pointed out that that's kind of just like a regular house. So, well, not my house, obviously, other people's regular houses where they're slightly intoxicated quite a lot of the time. So, you know, the way we think about these things, I think families get left dealing with a lot of stuff that the system doesn't know how to deal with. And while some families are well resourced to be able to take care of their own loved ones, I think actually as a system, this is part of that connectedness piece. And families shouldn't have to be acting because of a system failure. They should be able to prioritise not just the safety of their loved one, but their own safety as well, if that's what they need to do. And obviously, all of our systems are stretched and stressed. I mean, I would just note that the housing issues have been on the table for a really long time, and no matter what we do, we tend to just make it worse rather than better. So, you know, in my lifetime, we've been resolving the housing crisis, at least in remote Indigenous communities, for 30 years now, and we have not yet got there. So whatever it is, however we're approaching this, we're obviously not doing, we're not looking at the full range of options we should be looking at.
Thanks, Beck. And Kim, what about in an Aboriginal and Torres Strait Islander context? And, you know, particularly around a different even notion of family altogether. You know,
it's really difficult. I've worked on the forefront of housing women that have come out of prison. And to find housing is quite difficult. We always said that one of the hallmarks of Aboriginal and Torres Strait Islander culture is ways of life and ways of being, and relate to kinship connections to families in old ways. This was strictly regulated according to thousands of years of kinship laws. These ways meant that there was a reciprocal obligations and entitlements for all. No one was left behind. But now in today's Western society, this is hard to maintain. Our ways are now impacted by money pressures and by, living pressures, safety, security, employment, accommodation. It's not so easy to abide by the old ways now. When taking someone in might, introduce risk to your family, but you can risk of eviction and place money pressures on the families. So while old ways may not work as they once did, turning to old ways whenever possible should be still explored. So yeah, it's quite a difficult one. Yeah.
No, thanks, Kim. And Niki, what's your work in terms of families and carers of people with substance?
Oh my gosh, I don't have the answers for this one. It's huge. I mean, there's just more demand for services, for housing, for treatment than we can ever meet. QuIHN works with significant others, family and friends of people who use drugs. But yeah, I think we don't have enough. I mean, to start with, we ask people who are going into rehab and detox to, make a choice between housing. I think sort of Beck was touching on a little bit. We ask people to make a choice between, housing and pets or going into rehab. I think we need to look at different models of how we provide services. The service options at the moment are really narrow, and because there's not enough of them and long waiting lists, people have to choose services that may not fit their needs and may mean that they have to leave long-term accommodation in order to get the help they want. And people shouldn't be having to choose between accommodation or drug and alcohol support. So I mean, it has been good to see some different rehab models being offered for people, like day programs and things like that over the last couple of years. So that's been good, but I still think we need to do much better. Families shouldn't be having to make those decisions, and at the moment we're asking people, we're telling people to leave jail and get their life together, and we're putting them in really unsafe accommodation, and then putting all these kind of demand mandates on them to stop using and deliver urine screens and things like that, when we're unable to provide the support that people need to even think about meeting the demands of the system in that way. So it's really hard. I mean, we just need increased funding, increased options, and thinking outside the square in how we deliver services to people. It's actually really, really stressful working with people, particularly when it comes to housing. It's really depressing. It's when someone is ringing asking for support and you just know there's not going to be any options for them. I mean, it's just, I don't know. it's really,
housing supply,
really challenging
around the edges, aren't we?
Yeah. And it just I mean, it just, if we're asking families and significant others to pick up the slack there, then that leads to a whole bunch of other issues that is just going to likely, potentially land people back in jail or needing help again with the system. So yeah, it's I don't have the answer, but there's a lot to talk about, and we definitely need to do better.
Yeah. And hopefully the government's focus here in Queensland and nationally on increasing housing stock comes along fast enough to be able to at least. So look, a slightly related question comes from around involuntary treatment options, and this one pops up from time to time. What are the panel's thoughts about involuntary treatment for severe substance dependence when all other treatment options have been explored? Cam, what are your thoughts about this? Pops up in your space from time to time.
Yeah, it gets talked about in the youth area a bit. I mean, it's a tricky one. I think there definitely are cases that I've been involved in where, particularly with very young people, where as a community, we're sort of sitting back watching a 14-year-old destroy themselves, and we're actually hoping that they get put into youth detention because that's the only way that their safety will be guaranteed. Now, I think that before we ever think about involuntary treatment as an option, though, we should get a fully funded and functional voluntary treatment system, because it's hard to determine really at the moment what needs could be met from a better, fully funded, culturally appropriate, et cetera, AOD treatment system. So there are definitely, I know Victoria's done a lot of work on involuntary treatment options for young people. They have got a very good voluntary treatment system down there. There is a model that has been worked up in Victoria, which has been done in conjunction with the Victorian Aboriginal community controlled health organisations. There definitely is a way of doing those models in a way which is safe and ethical and respects the rights of young people and their families. I think there's a danger it's done poorly. I think there's other examples in Australia where involuntary treatment of young people has been as a stopgap measure just to lock them up because they're causing too much trouble in our in our child protection system. So for young people, I think there is a role for it. However, we have to be really careful that that does not become abusive, and it is genuinely therapeutic, and it involves the community and the families, and it's not just the government locking them up.
And Beck, do you have a?
Yeah, I got some thoughts. It's I agree with everything Cameron said to a point. I think the thing that struck me in 10 years in this job is that we're getting better at understanding that the predictors of success in treatment are heavily dependent upon two things. One is your rapport with your treatment provider, and the second is your belief in your self-efficacy. I struggle to see how any involuntary treatment model, as well-intentioned as it might be, doesn't trample on someone's self-determination. I'm not taking away from how difficult it is to watch people, as you know, especially young people, destroy themselves. But I think Cameron's got the right of it in saying we don't know what the benefits of a fully functional, funded, voluntary system are. And frankly, we've got a long way to go before we've got that. The other thing is that often for particularly the people like the young people that Cam was talking about, the substance use is merely a way of coping with the intervention of other systems that have either intentionally or unintentionally traumatized young people. I know I don't want to jump ahead to the question that points to the child safety and youth justice systems as two systems that do this. But the other part of this, I suppose, is that we live in I'm just noting that the government was this week given the report into the Commission of Inquiry into Police Responses to Family and Domestic Violence. You know, our history of colonisation hasn't ended in Queensland. It's an ongoing process. And so the risk of any involuntary treatment system is that it will target First Nations peoples and act as a secondary incarceration kind of stream. So I don't think we've got the foundation to be able to do involuntary treatment safely in Queensland yet. And I hope that if we build a really great voluntary treatment system, we'll never need one.
Yeah, I think we often don't provide voluntary services in a way that's, you know, not harmful, you know, so a lot of the voluntary services that we have are, you know, already, you know, talking about young people or people who use drugs destroying themselves. I think it's the systems that we have that are causing a lot of that harm for people who use drugs. So we currently have a voluntary system that could do a lot better. So I'd be really scared to see any kind of involuntary services for people who use drugs or people having issues with substance use. I agree with what Beck said, yeah.
Yeah, prison is our voluntary treatment kind of option.
Well, that's right, yeah, that's right. Yeah.
Hey, I'll move along because we are running out of time. Thanks, guys, for your comments there. I've got a quick question about Xanax and benzo use. Cameron, does Xanax or other highly novel high-potency benzos lead to more offending behaviour?
Unfortunately, kinda. Just because of the disinhibiting, and Xanax in particular has a bit of a reputation for causing disinhibited behaviour that people don't remember in the morning. And I know that we definitely have anecdotally heard this from a number of youth justice services who picked up new groups of clients, and their crimes are primarily under the influence of benzos like Xanax. There are definitely, I think the combination of the disinhibition can actually make people do things they otherwise wouldn't normally do. And and that causes all kinds of behavioural issues. So there's definitely been some of that. It's almost a bit of a cliche. The person who, mucks up in your service on benzos and is asked to leave and is back the next day and doesn't remember why they were asked to leave yesterday because they can't recall what they did. So it definitely can happen. I think we should be careful not to overstate it in a sort of stigmatizing way, but I think that those the benzos definitely do have behavioral impacts that are different in the way you manage it as well in a service.
Jeremy, do you have anything to add to that one?
So Xanax is no longer available. So anyone buying or acquiring Xanax, it's counterfeit and who knows what's in it. Alprazolam is the parent name of this potent benzodiazepine, which has a rapid onset and rapid offset. And that seems to be the key, as Cameron was explaining, to disinhibited behavior. It's a bit like drinking a very large quantity of alcohol very quickly. You do crazy things and have no recollection the next morning. I would reinforce the comments that Cameron has made. And of course, there are new benzodiazepines appearing on the illicit market. Etizolam is one. These are potent and have similar related effects, some very long acting. They all seem to be quite potent, which is probably their appeal.
And Jeremy, while I've got you, there's been a question around the effectiveness of naloxone, in particular the nasal spray compared to intramuscular naloxone or prenoxide. Do you know of any evidence relating to the effectiveness of either one over the other?
Well, thank you, Jeff. There's no doubt that giving naloxone intramuscularly is a good means of delivery. And a lot of work went into calculating the dosage required intranasally to give an equivalent effect. And I think they've come up with a pretty good solution. So there's excellent graphs showing the bioavailability of the two routes and the timing. And clearly one of the concerns is in treating someone with an overdose, you want to get your treatment in early because minutes, seconds count. And I think I would kind of reflect that the whole drama of loading up a needle onto a syringe and injecting it into a patient often takes significant time, and the contrast with the nasal product, which comes in a ready-to-use format. You have a nozzle which you insert in the nostril and squeeze and spray the naloxone into the nasal passage. That is much quicker. So any slower onset because of the transmucosal, the nasal delivery, tends to be countered by the increased time it takes to give an injection into someone who's overdosed. I think the topic of fentanyl also comes up. Is naloxone effective in fentanyl overdose? Fentanyl has particular properties which make it particularly dangerous. It reaches the brain much more quickly than heroin, and so for an overdose it may prove fatal in 5 minutes, not 30 minutes. It also has other effects on the body, so can cause this so-called wooden chest of muscular rigidity, which may mean someone who is overdosed is sitting up and not necessarily collapsed as someone from a heroin overdose might be. It's also a very potent opioid, of course, and there's less tolerance, it seems, from animal experiments. You can gradually increase the amount of morphine you give to a rat and they will survive. much less of an increase as possible before you overdose the rat with fentanyl. So there are a number of different aspects of fentanyl which make it particularly dangerous. If you are using naloxone to try and reverse a fentanyl overdose, fortunately in Australia that's not yet common, although in the States we've seen what's happened there, where most street supplied opioids have fentanyl in them, at least 50% of those supplies. We haven't seen that in Australia, but if we do, then the message is you keep administering fentanyl in bigger and bigger doses. And just a final point, the buprenorphine is really quite effective at preventing the respiratory depression which leads to death in fentanyl overdose. So a nice study looking at volunteers showed when they're receiving a big dose of buprenorphine, that will prevent the fentanyl-induced respiratory depression. So that's the final comment.
Thank you, Jeremy. Look, we are running out of time, so I'm going to have to choose which questions we get to at the for these last few. I am interested around this question because I'm sure it's an issue that affects a lot of people, is around engagement with statutory agencies like Child Protection and Youth Justice, and how do we work with clients or people in this substance use in a trauma-informed way, or how do we work with those agencies when they've also got legislative requirements and this kind of need to meet community expectations around community safety, etc. Cam or Beck or Kim, I'll throw that question over to you. How do we manage those relationships?
Yeah, we've been grappling with this for a while now, because obviously those systems have a big part to play in whether people succeed in their treatment episodes. And when we're looking at measuring the outcomes of treatment, then those things become really important. I note that the Achieving Balance plan notes that there will be a whole of government trauma strategy, and I'm really looking forward to how that gets developed. But I think there's some things we need to keep in mind. The first is, I don't think you can deliver youth justice in a trauma-informed way without first burning down all of our detention centres and sacking all of the people who work in the system and then building a new workforce with different qualifications. I'm not suggesting that that's possible, but I just think we need to be really careful that we don't hand these systems the language of being trauma-informed and then watch them inflict trauma. So that one of the really important things about trauma-informed practice, in my view, is the way it values the self-determination of the people who are being supported, that it cares about, that trauma-informed care cares about what matters to the people who are accessing services. And it doesn't expect that they will share every negative experience that's ever happened to them in their lives the very first time. So I've seen it suggested that we could do this by just adding a trauma screen to our assessment process. And I'm like, oh, no, a trauma screen would be the opposite of trauma-informed practice. Allowing people the dignity of choosing how they tell their story, who they tell their story to, and which bits of their story they think are relevant to the matter at hand, means that a trauma-informed system would start saying to those statutory systems, you're not entitled to the client's medical record, you're not entitled to the case notes from their counsellor. Like there's a measure of privacy in their interactions with their service providers. Sometimes this turns into, information sharing, and then the system just becomes everyone uses the same database. And what we see, particularly with child safety, with parents in the child safety system, is that they value the data from the record more than they value the relationship between the service provider and the parent. And in so doing, inadvertently, they could be making the child they're trying to protect less safe, not more safe. So we've got a long way to go before those statutory systems are aware of what they're good for and when they can be deployed, and when they're actually deployed in ways that are causing harm, rather than, I know we talk about the stolen generation as though it's a thing that happened in the past, but we're in the middle of a new one. Or did we ever stop? Like, we remove a lot of First Nations children from their family, and then a lot of them end up in the youth justice system. And we make the problem the young person and their ability to not cope with 7 systems in their life. And I think that has to change.
It may be, that's great, Rebecca. It may be getting to the point where the first priority is identifying the original trauma, what you just said, Rebecca, that led to the AOD misuse, or then treating that as a priority rather than the criminal or legal or legislative aspects of the, the first response. Maybe we need to do more of a marketing strategy to raise awareness of trauma-informed care. Then community expectations might change. And if the community expectations change, then elected officials, politicians, will feel more encouraged to introduce trauma-informed care. But right now they might not, because there's no votes on it. So, that's just my little take on it.
Thanks. And Cam?
Yeah, Kim's got a great point. I mean, I stupidly read the comments on the Courier Mail article yesterday about youth justice reforms. And I can tell you what they had to say. The common view was that they should be locked up harder and longer, that there's an underlying current that as children, we see them as victims often of child abuse or neglect or whatever. As soon as they act out on that as a 12-year-old, they're criminalised and locked up. So I think even within child safety and justice, we work really closely with those departments, and day to day, the staff we work with are really dedicated and trying to do the best they can. What we though see is a political problem whereby you look at the Townsville Bulletin and the Cairns Post and read the articles up there, and it creates this issue where government is expected to be tough on crime by locking them up, and actually doing what we know works is not politically attractive, because the public want blood and they want them locked up. And so it's a dilemma for politicians and how they lose elections over it, and so have to play this sort of game. And I feel sad for the departments that are meant to try and work within that, because I know that they are experts and they know what works and what doesn't work.
It's interesting, Cam, because that topical and crime rhetoric has been run really strongly in the far north in the last 2 state elections and the last 2 federal elections, and 0 seats have changed hands. So this is like that time that they don't think decriminalisation is supported by the community, except all of our research says that it is. It's really interesting to watch them catch on to the fact that actually you don't need to react to that tough on crime stuff anymore, because most people don't believe it anymore.
All right, we could go on for hours around that particular topic by itself, but we only have a couple of minutes left. So I'm going to skip all of the other questions, and I'm sorry to everybody online who submitted a question that we didn't quite get to. We can save them up for next year. Might be the same, might be a perennial issue. But I'm going to throw to the final crystal ball kind of question. Before we depart for our end of year break, what are the big issues, trends, or things to prepare for in 2023? What's on our agenda for the new year? And I'll throw to you firstly, Niki.
I don't know. Well, I would like to see us commit to building, growing, supporting a peer workforce. For real across the AOD sector. I'd like to see more peer work opportunities and positions, and also not just frontline, low paid, entry level positions, but positions of leadership and management and systems, and systems change type positions as well. I think some of that's starting to happen, but I'd really like that too. I know it wasn't a wish list, it was a crystal ball thing, but yeah, that's
good. I'll move on.
That's what I'd like. Yeah.
Kim.
Yes, it's about truth-telling, the link between trauma, colonisation, social determinants of health, and the manifestation of that in AOD issues. Yeah. And it's one of the positive things that Metro North Health Equity captures, that intent. So that's my message.
Yeah, excellent. Thank you. Jeremy.
Thanks, Jeff. So I'd like to see, this is not crystal ball, it's wish list, seamless care across sectors. So between public clinics and GPs and prisons and other environments, so that patients don't get lost. And that means you need good information systems and good communication between clinicians.
Thank you. And Cameron.
I got a crystal ball. It's not a good one. I think we're going to see more and more toxic drugs entering circulation and poisoning people. I think nitazines, synthetic opioid nitazines, are about to hit. And if you look overseas at what's happened, I think that we're on the pathway to more and more toxic drugs circulating, unfortunately.
I think that's a bit of a mood wrecker. And Beck.
Thanks, Cam. I reckon We've keep your eye out. There should be a new parliamentary inquiry into possession of utensils with a gender lens over it, given that 85% of the growth in our women's and girls in prison is driven by illicit drug offences. And I think a gender lens on our drug problem will be a game changer in terms of shifting our criminalised thinking. So yeah, keep your eye out for that in the new year. And the other thing that kind of connects to that is around family and domestic violence capability within our service systems. We've got a lot of men aged 18 to 44 with emotional regulation problems. I think it's reasonable to expect that some of them will be men who use violence in their relationships, and we need to really focus on that.
Here. Well, thank you everyone on the panel. Round of applause for you all for a very exciting, interesting and engaging discussion. This is our last webinar for the year, so I want to quickly thank a few people like Michelle and Jackie who created this semester's calendar, our behind the scenes team, Ben, Niall and Crystal, for making it all work. We want to thank our partners at APSAD for the program each year. And yeah, lastly, thanks again to our panel presenters for the discussion. It was really, really great. Fireside chat. So we're going to wish you all and all of our audience members a great end to the year. And I hope you have a safe and happy holiday season as we near the end, and we look forward to seeing you back for our webinar calendar in 2023. Please do the survey. Thanks again for the chat and the discussion, and we bid you a great day and week. Thanks everyone.
Thanks everyone. Thanks Jeff.
Thank you.
Bye.
Bye.
Bye.